BRELEN from Hong Kong to talk to us about case studies, yeah, and blow some myths. Right?
Yes.
Yeah.
Yes, we've got a two-part talk. We're going to look at some cases, and it's up on the screen. So
Yes, I got it.
let's give it a go on this one. Okay, great. Thanks again for the opportunity to present today. We're going to look at some cases and, as we mentioned, resolve some of these myths and misconceptions. I have no relevant financial disclosures. We talked this afternoon about a number of conditions that can be treated with micropulse laser. I'll be focusing once again mainly on CSR. Anand gave a beautiful talk on diabetic macular edema. There was a question earlier about retinal vein occlusions. I'll confess myself, I've never tried it in an RVO. And there's even talk about using micropulse after retinal detachment surgery where there's persistent subretinal fluid. And I know Barbara has mentioned this before, Barbara Parolini. My experience comes predominantly from, as Lite mentioned, a clinical trial that we published last year, a prospective RCT comparing half-dose PDT with micropulse. And this was a fairly comprehensive study. We followed the patients up at very frequent intervals and followed them for a whole year with resolution of subretinal fluid being the primary endpoint. And at each visit, we did really comprehensive investigations of the patients. So we've got really good imaging data showing the course of events that happens after micropulse laser treatment. I won't persevere on this point, but titration, making sure you've got the right spot size and the spot density and following the guidelines from SOLS is absolutely critical in order to get good treatment results. I think myself, and this is just my own anecdotal feeling, is that when you treat with micropulse in CSR cases, you either get patients that just need a single treatment and then they go dry and then they're fine. You get a few that have a recurrence and then they have a repeat treatment and they go dry. And a very small group have a persistence that requires you to be a little bit more perseverant with the treatment. So let me give you some of these cases. So again, my cases are all chronic or recurrent CSR cases. So the patients are a little bit older. This is a male, 54 years old, right eye CSR with a vision of 20/30 with blurring and metamorphopsia for 3 months. And you can tell it's chronic because you can see on the autofluorescence that the RPE is really quite sick. And on the fluorescein, you can see the main area of leakage just above the fovea. And to answer the lady's question from earlier, all these patients had fluorescein and ICG at baseline and before any retreatment. Here's the fluid, 426 micrometers central subfoveal thickness. Here's the spot size if you were interested to do PDT. All these cases had micropulse. And you can see with just a single treatment in October of 2019, some 4 weeks later, the retina is completely dry, and the vision has now improved to 20/25. The retina remained dry until the final end point of the study, which was 1 year, and in October, when the vision had further improved to 2018. So this, I have to say, is the overriding majority of cases that I had in my micropulse treatment group. This case is a little bit different. First of all, a bit unusual because it's a female, but presented, and also a hyperope, which is really unusual for Hong Kong, but presented with reduced vision for 6 months in the left eye with a vision of 20/25. This was probably not a chronic or recurrent case because, as you can see, the autofluorescence looks pretty good, and you get a single ink blot leakage on the fluorescein. The fluid was 422 central subfoveal thickness, and you can see quite clearly the correlation between the fluorescein and the leakage spot causing the fluid accumulation on the OCT. Here's the spot size on ICG if we were doing PDT, but this lady received micropulse in October of 2019, and then some 6 weeks later, vision had improved to 20/20 and the retina was dry. We were very happy, but then unfortunately some 3 months later there was a small recurrence. You can see a little bit of fluid, and the same area of leakage has a recurrence on the fluorescein angiogram, and the vision dropped back down to 20/25. No big deal, we just simply repeat the treatment, and as the speakers have alluded to this afternoon, you can repeat the treatment many times over without much concern. So a further treatment was done with micropulse, and then some 6 weeks later, the retina is dry again with a vision of 20/20 until the end point of the visit, when the retina remained dry and vision was 20/20. Here's a more typical scenario of a young male with 20/18 vision, both eyes, but complaining of a scotoma for 9 months in the left eye. You can tell that this is also chronic just from the fundus photo. You can see some RPE change in drusen. And on the fluorescein, interestingly, the site of leakage here is quite close to the disc. Again, this is worth debating, you know, that if you were to PDT this, it would be perilously close to the disc and may not even be reachable, given that you have to be 500 micrometers away from the disc to do the PDT. Whereas with micropulse, you simply treat the whole area where the fluid is. That's exactly what we did for this case. Here's the OCT at baseline. Here's the spot size, which has been displaced to the right because we need to be a little distance away from the disc. And the vision improved even further. So presented with 20/18, but became 20/16 at 6 weeks after the first laser treatment. There was a small recurrence once again a couple of months later. Again, the same area was leaking, and a further micropulse laser was done, and the retina remained dry for the duration of the future visits, with an end result of 20/20 unaided and a dry macula. So on to the second part of my talk, which is to try and dispel some of the common myths that I hear about micropulse laser. And these are not quotes that I've generated out of thin air. This is approximately 10 to 11 years of experience with using micropulse. These are actual comments that have been made by my colleagues working in the same department. Okay, so these are genuine things that we have to deal with on a daily basis when we're trying to convince doctors that use a lot of PDT that they should be switching to micropulse. So myth number one is I don't want to use micropulse because the visual acuity gain is likely to be better with photodynamic therapy. That one we can dispel because we now have our randomized controlled clinical trial on CSR comparing PDT with micropulse laser, and we see equivalent visual acuity gains in both treatment groups. There is no statistically significant difference at any visit for an entire 1 year duration of follow-up. And both groups had, as you can see at the bottom of the slide, a statistically significant improvement from baseline regardless of which treatment. So we can dispel myth number one that you get better outcomes with one type of treatment compared to the other. Myth number two, I don't want to use micropulse because the drying effect of photodynamic therapy is better. And I should stress this point because this was one of the outcomes from our publication last year. Unfortunately, it's been slightly amplified since the publication, and I want to put the record straight here, which is that the drying effect, and here you can see the central subfoveal thickness on OCT in the micropulse versus the half-dose groups are equivalent. The drying effect is no statistically significant difference at any time point, and there is a significant improvement in both. Where there's a bit of controversy is that the drying effect was marginally faster in the PDT group. But I would argue that the difference was so small that it's clinically not relevant. And it was not statistically significant at any time point. There is a small difference in the Kaplan-Meier plot, which I haven't got here for you now, but you can have a look at in my publication, that the drying effect at 3 months was marginally faster. But by 6 months, there is no difference once more in the two treatment arms. So I don't think there is much difference here between the drying effect of the two treatments. Myth number three that I've heard a lot, I don't want to use micropulse because I hear it damages the RPE. I think we've dispelled that one already because the basic science has been demonstrated already to show that there's no damaging effect to the RPE. I guess what I can add is that for all of our patients at every visit, we performed microperimetry. So we have really good longitudinal data on retinal sensitivity using microperimetry. There is a good improvement in retinal sensitivity in both treatment groups, and again, no statistical significant difference at any time point between the two treatment arms. Here's just an example of the microperimetry results showing the improvement in retinal sensitivity after micropulse laser, for example. Here's another thing I hear, which is I don't want to use micropulse because I've heard that the recurrence rate is much higher if I use micropulse than if I use PDT. And I think the argument here that some doctors use is that because PDT performs this choroidal vascular remodeling, as they call it, I just call it burning the choroid. The choroidal vascular index and the choroidal thickness is reduced after PDT, which is not in micropulse. And people extrapolate that result to suggest that because the choroid is still thickened and because there's still pachychoroidal features, there must be a higher recurrence. We've actually now, and this is hot off the press, we called back all of the patients from our clinical trial in a retrospective manner, asked them about what happened 1 year after they exited the study. And we've, spoiler alert here because this is now being reviewed and will shortly be published, hopefully. There was no statistically significant difference in the recurrence rate between the two treatment arms. So the recurrence is there in both treatments, and there's no difference between the two groups. And the last one is I don't want to use micropulse because patient satisfaction must be better with PDT. And actually, it's the reverse result that we found in our study. When you looked at the visual function questionnaires, it actually scored higher in the micropulse group than it did with PDT. And interestingly, this was also found in the PLACE clinical trial. So for all its flaws, it actually found the same result as us, which is that patient satisfaction is slightly higher with micropulse. So in summary, in Hong Kong and in my department, we are switching most, if not all, of our CSR cases over to micropulse now. We have, just like everyone else, a supply chain shortage of verteporfin. Verteporfin is a self-financed item in Hong Kong. It's extremely expensive for the patients to use. We like to use micropulse just even from the setup of the clinic point of view because we don't need to put in infusion lines, get the infusion running of verteporfin, wait 15 minutes and then do laser. We just simply take the patient to the laser room, do the laser and then send them home. And we also don't need to give them lots of worrying things like don't expose yourself to sunlight afterwards, wear dark glasses and cover your skin. It's just like any other laser, so it's just infinitely more convenient to perform. So with that, I thank you all for your time and attention, and I welcome you all to Hong Kong next year for AIO2026. Thank you.
Do we have any questions for Marten?
I have a follow-up questions about the RVO. So which parameter do you use for RVO case? The CSLR or the DMA one?
Yeah, I prefer to use the DME parameters. Yeah, because it's a edema, similar to DME. So it's that. I'd just like to touch upon that last thing. We were both lit and we were surprised that people felt that the happiness quotient was more with PDT, considering that with PDT you have to be fully covered and wear a cap and have a Venflon and have an injection inside, whereas with micropulse it's walk in, walk out. It's just a 10-minute job. So I'm surprised people would think that patients would be happier with PDT. So much more difficult, so much more expensive.
But I think also adding to this is a sort of stubborn mindset that I noticed, particularly in the area where I work, where PDT has been the gold standard for so long, and unfortunately what happens is that times don't really move on with the training as well. So even when the residents of yesteryear now become consultants, they're still teaching the residents that PDT is the only treatment available because they've never even tried the micropulse, even though we have really good clinical trial data on the local cohort population to show that this works really well. So changing mindset of, dare I say, some of the more senior retina specialists is really difficult, and they're very reluctant to try new things.
Other thing we didn't really touch upon here was also the use of eplerenone for CSCR, especially where you have diffuse RP damage. So a lot of people have been doing that, and that came into vogue or surfaced a little more when PDT was on its way out of Visadign, was going off. But then the issues with hyperkalemia and having to continuously monitor the potassium levels and the patients at risk. Some of these patients with a lot of diffuse RP damage, unfortunately, are also cardiac patients. So you're not taking a risk, you're putting something into the body, and there's a systemic ramifications for that. So that's another aspect. So therefore micropulse as a local treatment doesn't need, you don't need to do all that. So from that point also it's far safer. Yeah. Jay, you want to add something? Yeah.
I'd like to make a comment also, if you remember from the AMD days that we used to do PDT, remember that around 4% of patients that underwent PDT had severe visual loss. And I think that the trials that plays, Marten's trials, didn't show that because just the numbers were probably too small, but if you do it long enough, maybe, you can get that as well. So
So yes.